Dear colleagues, I'd like to greet you all in our seminar series that are organized by the Armenian Eye Care Project, Malayan Ophthalmological Center, and Yerevan State Medical University. I'm Nuna Yaghyazarin, Armenian Eye Care Project Director. It is already a few months that we are performing this new educational initiative, and I think that it enriches our seminars and our educational activities. Our meetings are performed regularly and mostly once per month. They are covering a specialty. I would like to say that during this event, we hosted more than 100 specialists, and today we will be talking about glaucoma, and it will be performed by our Armenian and American colleagues. I would like to mention also that during this meeting, we will meet our fellows, Lilith Voskanyan and Vahan Papoyan, that are representing first and second generations of our fellowship project. And today, our project will be chaired by Lilith Voskanyan. She's the head of the glaucoma department of the Malayan Ophthalmological Center. Also, she's head of the Department of Ophthalmology at Yerevan State Medical University, and she's the fellow of the Armenian Eye Care Project. From the U.S., Dr. Richard Hill and Dr. Jay Katz have joined us, and Dr. Richard Hill is from California University, assistant professor of ophthalmology, and Dr. Jay Katz is the member of Glaucoma Service of Wales, professor of Sidney Kimmel Medical College of Ophthalmology. I'm sure that our discussions and our case presentations today will be very useful and they will be interesting for our colleagues. Now, dear Dr. Lilith Voskanyan, please.
Good evening. Maybe I'll talk about English. And as the first, I would like to say good morning to Dr. Hill and Dr. Katz. Dr. Hill, my teacher, and the person who has done so much for Armenian ophthalmology, especially in glaucoma area. Thank you very much. I know how busy you are, and you spend this time with us to talk about the problems with glaucoma and to share with you our knowledge and our two topics today. And hi, Dr. Katz. Thank you very much for your time here. It's been already a long time. We didn't meet each other, but there are lots of things we have done in the past. And today with us, Vahan Papoyan, who is the second best and the doctor of glaucoma department and associated professor of the department. And, he has gone with AECP program as a second best for glaucoma area. And Dr. Katz was his supervisor for that period. And Dr. Papoyan came back with very new knowledge and very excited and very happy with the time he spent there. And also with us today, two residents, third-year residents, who are right now spending their period with the rotation in glaucoma department. And they are going to introduce you to topics. One will be with Grigorian Lucine, and she will introduce iridocorneal endothelial syndrome with our cases, and will share with you knowledge, skills about that, and our experience around that. And also Dr. Lilith Voskanyan, who is going to introduce you neovascular glaucoma as a disease which still again a problem for glaucoma, etc. And before going to talk about the topics, before the residents will introduce it, I would like again to say thank you, Armenian Eye Care Project, Dr. Hill, Dr. Katz, Dr. John Ovanesian, especially Raja Ovanesian and Nuna Yaghyazarin, who has done a lot. I would like to say thank you, Malayan Eye Center Director Josep Mirian, who did all this possible and made this conversation here. And thanks to all my colleagues who are right now joining us for this evening. Thank you very much. And let's go. And the first topic we are going to introduce will be with Lucine Grigorian, third-year resident. She will introduce you iridocorneal endothelial syndrome with pathogenesis, treatment, and signs. Lucine.
Hello, dear colleagues. I want to say thanks to Armenian Eye Care Project, to Ophthalmological Center Dr. Malayan, and to Head of the Glaucoma Department, Dr. Voskanyan, for this opportunity. Today, we're going to talk about iridocorneal endothelial syndrome. Iridocorneal endothelial syndrome is a rare disorder characterized by proliferative structural abnormalities of the corneal endothelium that leads to varying degrees of corneal edema, iris atrophy, and secondary aneuplosia glaucoma. It's presented as a unilateral disease, more common in women between ages of 20 and 50. Glaucoma is present in approximately half of all cases. Etiology is unknown, but it has been theorized that underlying viral infection can lead to a low-grade inflammation at the level of corneal endothelium, resulting in its unusual epithelial-like activity. That cells migrates posteriorly, moving beyond Schwab's line onto the trabecular meshwork and iris. Contraction of that tissue within the angle and on the iris results in its high peripheral anterior synechis and iris changes characteristic of IC syndrome. Secondary glaucoma is because of hypes, but the endothelial cells can also functionally close the angle without contraction. The corneal edema is secondary due to high intraocular pressure and subnormal pulp function of the corneal endothelial cells. There are three types of IC syndrome. First one is iris nevus syndrome. Here we can see pigmented nodules or diffuse pigmented lesions on the anterior iris surface. Chandler syndrome is the most common type. Here we can have corneal angle changes with minimal iris atrophy. And the third one is essential iris atrophy. Here we can have different degrees of iris atrophy, chorictopia, polychoria, and hole formations. The most common symptoms are monocular pain, blurry vision, iris changes, and irregular shape or position of the pupil. Diagnosis is based on clinical characteristics, visiometry, tonometry, biomicroscopy, ophthalmoscopy. Biomicroscopy shows bitter bronze appearance of the corneal endothelium, corneal edema, iris pupil changes. With gonioscopy, we can see characteristic findings of IC syndrome, peripheral anterior synechis. But when we have poor visualization due to corneal edema, we can also use ultrasound biomicroscopy or anterior segment OCT. And the last one is specular microscopy. Here we can see asymmetric endothelial cell loss, atypic morphology typically present. These cells are dark with dark areas and central highlights. We can call them IC cells, pathognomonic to iridocorneal endothelial syndrome. For differential diagnosis, it is important to think about following diseases. Corneal endothelial dystrophies. Here we can have similar corneal changes without angle or iris changes. Axenfeld-Rieger syndrome, it is bilateral congenital disease. And here gonioscopy can help us to do differential diagnosis. Aniridia is also bilateral and congenital disease. Here we have cataracts, glaucoma, foveal or optic nerve disc hypoplasia. And the last one is iris melanoma. When we think about iris nevus syndrome, first of all, we should exclude iris melanoma with ultrasound biomicroscopy. Management. Topical medication is the first-line therapy for these patients. Specifically, aqueous suppressants are typically used. Due to theorized role in HCV, we should consider addition of prostaglandins should be carefully considered because latanoprost can reduce and also we can use topical hypertonic saline solutions to reduce corneal edema. When our medical therapy is unsuccessful, we can also use surgical therapy, trabeculectomy with antifibrotic agents or glaucoma drainage implants. When surgical therapy is not obtained, it can be necessary to do ciliary body destruction procedure. Also, corneal decompression also can be treated with surgical therapy with penetrating or endothelial keratoplasty. And here is our first case, 42 years old female presented to our clinic with complaints of monocular pain and loss of vision for about 3 years. She noticed that she had problem in her right eye for about 10 years and treated with Betopsic S all that time. Examination showed that vision acuity in the right eye was light perception, and on the left eye was 1.0 with best correction. Intraocular pressure by Goldman was 14 in right eye and 12 in the left eye. Biomicroscopy showed corneal edema, nodules on the anterior iris surface, and dilated pupil. Ophthalmoscopy showed cup-to-disc ratio in the right eye was 10 to 10. First of all, we concluded with UBN that there is no underlying tumor alteration of the iris and ciliary body. The next step was gonioscopy. Here we can see specific findings of the angle, especially in the inferior part. Also, we tried to do specular microscopy, but due to corneal edema, the results were not accurate. And our final diagnosis was iris nervous syndrome. Here we suggested to perform surgical therapy, glaucoma drainage implants, but due to financial issues, we decided to do trabeculectomy with antifibrotic agent, mitomycin C, to improve corneal edema, to decrease intraocular pressure, and to save eye. And our second case, 46 years old female, presented to ophthalmological center after Milan with severe pain in the left eye. She noticed that she had problems in the left eye for about 4 months and treated with taflotan. Examination showed that vision acuity from the right eye was 0.02 and intraocular pressure by Goldman was 45. Biomicroscopy shows in the right eye corneal edema and dilated pupil. With gonioscopy here, we can see dyskinesis of the angle, and trabecular measure was not fully formed. We decided to do ultrasound biomicroscopy to exclude iris or ciliary body melanomas. And here in the left side picture, we can see corneal edema and functionally closed angle. So our final diagnosis was iridocorneal endothelial syndrome. Here we had the same problems as in our first case, so we decided to do surgical therapy, trabeculectomy with antifibrotic agent, mitomycin C. And our conclusions, iridocorneal endothelial syndrome is a rare unilateral disorder, more common in women between ages of 20 and 50. Glaucoma is present in approximately half of all cases, and early diagnosis and diet control can prevent glaucoma and vision loss. Thank you.
Thank you very much. We didn't finish up that. For one case, we finally did an implant into the eye to treat the glaucoma. For the other patient, due to the financial condition, the trap was done with mitomycin C. And I think, Dr. Ik, what do you think? And Dr. Katz would like to share with you, because this is relatively fresh case. When doctors were preparing these cases, this was just before our plan. We were planning a little bit earlier to have this conversation. And that's why we would like to share with you, what do you think about these cases? Maybe the photos were not very clear, but in terms of biomicroscopy, of course, we have seen the iris, atrophy parts, and the nevus part as well. What would you suggest for this case, Dr. Jen?
First off, the presentation was very thorough, and I appreciate that. I think probably for Armenia, there's one other thing that is local to the area that probably should be included in. That's your Frank Kamenetsky syndrome. But I think that probably the presentation is quite a bit different. As I recall, they had some sort of GI upset earlier and then uveal inflammation. I think that it's interesting that iris melanoma is still in the original differential diagnosis. The original paper, I think, by Ralph Eagle and Yenoff, that I think unfortunately was in an enucleated eye. Hopefully it was a no light perception eye, but as it was originally described. I think probably the success rates are a little bit lower with trabeculectomy and antimetabolites than what you'd like. And I think that I would probably limit cyclodestructive procedures in eyes with chronic angle closure. Jay's kind of laughing there. I can't hear him, but
yeah. Dr. Hill, with cases with Frank Kamenetsky syndrome, this is again, I remember our conversation with you that Frank Kamenetsky syndrome is like some type of essential iris atrophy or iridocorneal endothelial syndrome, but we were calculating is that a bicolor iris. And you remember, and it's interesting right now when we see with our resident the cases, you remember about 50 years ago, how often we were seeing Frank Kamenetsky syndrome, bicolor iris. Right now, we don't see it. We have never seen the cases. And we were thinking that time that this could be even with some uveopathies or with the treatment or antibiotics right after with newborns that time. But right now, it's interesting. We don't see this bicolor iris.
That's a good thing.
Yeah, it's interesting. And what we think, why we don't like it, as you taught us that the cyclodestructive procedures we do at the last time, if there is nothing to do, only destructive procedures, we do at the last point. And I think the trabeculectomy, of course, the failure is more often than like that. And we wanted to see if the pressure, when the pressure comes down and the corneal edema goes away, how much the visual acuity will increase. If this is counting fingers from 5 meters and the corneal edema goes away, if the vision comes better, and then in future, if it doesn't help and the trap fails, maybe we'll think about Ahmed valve, or even we do pressure flow implant for those where we have conjunctiva healthy. Dr. Katz, Dr. Hill, do you have anything to tell? Or
okay.
Dr. Katz, we don't hear you.
Jay, check and see if your mute button is on.
Yeah.
Sorry, I had some technical difficulties. I missed the beginning part of the discussion there, but everything that Dr. Hill said, I agree with.
Chicken.
That's very smart of you. Dr. Katz, thank you. We were talking about iridocorneal endothelial syndrome, and we had iris nevus, you saw that. And I think, I would like also to talk with Vahan Papoyan. He's a scholar of you, Dr. Katz. He spent very nice time with you, learned a lot from you. And
we were glad to have him. He was a great addition for us. So it was a pleasure working with him.
And I would like to know his opinion as well as your scholar. And then if you will agree with Vahan Papoyan as well, then we are done.
I think I undoubtedly agree with him as well as with you, Lily. I'm sure that you all gave great recommendations there. But I assume that you were talking about eye syndrome, and I caught the end of the discussion about trying to do some type of filtering procedure. I gather for controlling the pressure, and I think that's certainly the standard of care for when you have failure of medical therapy, which often is the case. And TRABs can close, as you may have discussed before, with the membrane closing the internal ostomy. Sometimes it can be reopened with laser and get it reestablished again after a late failure. Tube shunts often can be used. And I haven't really not any experience with some of the new stents, whether it's mixed procedures or whether it's using Zen or PreserFlow. So I'm sorry if I missed that part of the discussion, but that's kind of a new realm of possibilities for treating that disorder as well.
With PreserFlow, we have already like a big experience about 80 PreserFlow implants for 18 months. But for these kind of cases, the most important thing to have very healthy conjunctiva to allow PreserFlow to work. So that's why we have done even with Sturge-Weber syndrome PreserFlow. But for eye syndrome, mostly Ahmed valve surgery is going to work very well. Or trap with mitomycin C with anti-metabolite, with, of course, thinking if it doesn't help, then will be another step to do.
So I have a question for you. Since you mentioned that Zen or PreserFlow could be used, perhaps if the conjunctiva was mobile, but if it's not mobile superiorly and it's scarred, would you consider putting in PreserFlow or Zen infranasally?
Yeah, we can do, but we have not done yet because it's just the beginning. I know that theoretically it can be done, but I don't think because for a proximal part of PreserFlow, the conjunctiva bleb should be formed. And with inferior eyelids, sometimes we are a little bit more skeptical doing it at the last point. And the conjunctiva is healthy, but we have very tight inferior eyelid. That's why for PreserFlow we have not done, but in future, if something as we develop doing this surgery, we will be more advanced with experience, more experience for PreserFlow, then maybe we'll think about that one.
Yeah, the reason I bring that up is because we are taught, and I'm sure Dr. Hill was taught the same thing, that trabeculectomies inferiorly are a no-no because of the risk of bleb infections. So we were always told to shy away from doing trabeculectomies inferiorly. It was just not an option. But on the other hand, we put in tube shunts inferiorly all the time. And so the question is whether these stents that don't have a reservoir, they do push the filtering bleb to some extent more posteriorly. So maybe there's a less risk of a bleb infection with these stents as well. So does that open another possibility for surgery? Putting in stents inferiorly that create filtering blebs. So that's the reason I brought that up. I have no experience with it, but that's been a topic of discussion recently amongst other physicians in the U.S.
Thank you very much. We'll keep in mind that. Also, I would like to know Dr. Vahan Papoyan's opinion about this condition, this introduction. Dr. Papoyan, what do you think about these kind of cases and your experience, your thoughts about it?
Thank you very much, Dr. Voskanen. Let me just first of all say thank you for this opportunity, and also thank you for my great teachers, Dr. Voskanen, Dr. Hill, Dr. Katz. Thank you very much. So I honestly, let me just enjoy it, because when talk specialists like you, I just enjoy and listen and learn. Thank you very much.
Dr. Katz, do you agree with Vahan Papoyan?
So if Dr. Katz agree with Dr. Hill, I agree with Dr. Katz.
I knew that Dr. Vahan was very smart, and that was a very, very diplomatic answer.
Thank you very much.
Thank you very much.
What do we also think about the mixed surgeries for stents? Not a draining stent, but our stents, which we do. Since this was very advanced case, these two cases were very advanced. And when optic nerve is gone and already the outflow from Schlemm's canal and then later on is not working, those stents will not help, as you already said. So the drainage implants would be better.
What if it was not advanced? Would you consider that?
Which one?
Would you consider trabecular meshwork stents in a case of eyes that did not have advanced damage to the optic nerve?
If the optic nerve is not very much damaged, but we have this kind of synechia formed in the angle, and we have lots of changes in the angle. My opinion that even architectonically, the angle is not formed very well. So even with this case, I will be more delicate, will not do the stents for trabecular meshwork. I don't think it will work. How do you think?
Yeah, I agree totally. I would never use a trabecular stent in a situation like this.
Thank you very much. Can we continue with our second topic? Thank you very much. And the second topic will be introduced by Lilith Vulkasyan. She is going to introduce neovascular glaucoma. Although the diabetes is mostly under control, but we still have problems with neovascular glaucoma. Lilith.
Hi, dear colleagues. Thank you for this opportunity to present you neovascular glaucoma in this meeting. Special thanks to Dr. Voskanyan and Armenian Eye Care Project. And so may I start? Neovascular glaucoma. Neovascular glaucoma is a potentially blinding secondary glaucoma characterized by the development of neovascularization of the iris, elevated intraocular pressure, and in many instances, poor visual prognosis. Neovascularization is a multi-step process that involves complex interaction of variety angiogenic actors. New vessel formation in the eye is detected by large extent by an imbalance between pro-angiogenic actors and anti-angiogenic actors. The main cause is chronic retinal hypoxia, which leads to increased VEGF. It migrates into anterior chamber, causing neovascularization of iris and angle. And then new blood vessel blocking trabecular meshwork, causing open angle glaucoma. Later, invasion of anterior chamber by fibrovascular membrane, causing secondary ankylosing glaucoma. In this slide, schematically depicted normal vessels of iris, and new vessels of iris, and peripheral anterior synecdoche. The most common causes of neovascular glaucoma are central retinal vein occlusion, proliferative diabetic retinopathy, ocular ischemic syndrome, central retinal artery obstruction. In this table, the conditions that can lead to neovascular glaucoma summarized and divided by common causes. As I mentioned, uncommon causes like ocular tumors, systematic diseases, and other rare diseases. Clinical symptoms and signs include watering, defective vision, photophobia, ciliary injection, corneal edema, high IOP. If the IOP elevation is severe, acute, the patient may exhibit severe pain, headache, vomiting, or nausea. For diagnosis, it is important visiometry, tonometry, biomicroscopy, ophthalmoscopy, perimetry, OCT, gonioscopy, ultrasound, wet scan, retinal fluorescein angiography. We can notice visual loss, high IOP, but it can be normal in the early stages of diseases. On biomicroscopy, we can notice rubeosis iridis, mild anterior chamber action, corneal edema due to sharp increase of IOP. On fundus examination, we can ophthalmologic glaucomatic damaged nerve can be present. On gonioscopy, we can see the corner angle neovessels, peripheral anterior synecdoche. Initially, the corner angle can be open in gonioscopy, but with the progression of diseases, new vessels will appear. The progression of the iris rubeosis to advanced stages of neovascular glaucoma can be broken down into 3 stages. The first stage, IOP is normal or slightly elevated. Neovascular iris can be with or without neovascularization of angle. Vascular tufts at papillar margin. Second stage, elevated IOP, increased neovascularization of iris and angle, no synecdoche angle closure. Stage 3, elevated IOP, reduced visual acuity, synecdoche angle closure. For the treatment of neovascular glaucoma has some specificities comparing to other types of glaucoma. It includes medical treatments, photocoagulation, vascular endothelial growth factor inhibitors, anti-glaucoma surgeries. The whole complex of this treatment is important to achieve a good result. On the strategy of medical management consists of against that IO lowering against like beta blockers, alpha-2 agonists, carbon inhibitors. They suppressing output production and increasing ovascular outflow. Prostaglandin analog should be avoided in order to prevent further intraocular inflammation. Recently, anti-VEGF management of neovascular glaucoma investigated because they can do both reduce intraocular pressure and reduce neovascularization of iris and anterior chamber. In this case, our patient has neovascularization with a hyphema, and we needed to do anti-VEGF injection in anterior chamber. Anti-glaucoma surgeries is also necessary because the use of eye drops may not lower IOP enough to prevent optic nerve damage. Anti-glaucoma surgery include trabeculectomy with antimetabolites, which is mostly not effective. And Ahmed glaucoma well surgery is reliable alternative to trabeculectomy. Ahmed consists of thin elastomer membranes that can open and close in response of IOP variations. And now our case for discussion. 63-year-old male with known proliferative diabetic retinopathy presented to Malayan Ophthalmological Center with complaints of pain and vision loss of the left eye. His vision problems in the both eyes is for about 50 years, and he was treated with taflotan. At the eye examination, we noticed that visual acuity on the left eye is 0.03, and intraocular pressure in the left eye is 36 by Goldman. On biomicroscopy, we notice rubeosis iridis, mild anterior chamber, mild dilated pupil. On ophthalmoscopy, we notice cotton wool spot, abnormal growth of blood vessels, hemorrhages, exudates. Camptosis gradual on the left eye is 9 to 10. We diagnosed neovascular glaucoma and started our treatment. Our plan was anti-VEGF injection, Ahmed glaucoma valve surgery. And after surgery, we noticed that his visual acuity on the left eye increased to 0.3, and intraocular pressure in the left eye decreased to 16. Neovascularization is also decreased. Although the valve decreases the mechanism decreases the postoperative IOP reliable complication, Ahmed glaucoma it can not be avoided the complications like hypertony, IOP increase, and exclusive capsule fibrosis, tube exposure, corneal complication, infection and endophthalmitis, diplopia, and strabismus. And despite the null inspections, cases of neovascular glaucoma is common. And during the year in the eye center of Malayan, in glaucoma department, glaucoma department operates approximately 70 Ahmed valve surgeries, where the most patients were diagnosed with neovascular glaucoma. Neovascular glaucoma is potentially blinding disease. Early diagnosis and aggressive control of high IOP and the underlying etiology is crucial to minimize the visual loss. Once IOP becomes elevated, successful management of the disease becomes extremely difficult. No current medical or surgical treatment has a high success rate. Thank you.
Thank you, Lilith. We are back here. The neovascular glaucoma still again, we see very often, and as Dr. Lilith said, at Malayan Eye Center Glaucoma Department, we do about 60, 70, even more PAMED valves per year, which means that neovascular glaucoma is still a problem. And you saw with this case, the patient, 63 years, it's relatively young age, but it was the only eye with pseudophakic eye was the only eye, the other eye was gone because of absolute glaucoma and the retinal detachment, and pressure was relatively okay, but no vision. And this eye we were going to again to treat to save. That's why the first treatment is like you treat the initial disease, then you go to treat glaucoma itself. And visual acuity came he was very happy, and we were as well happy because from counting fingers from about 2 meters, visual acuity came to 20, 60, something like that, even a little bit more. And we expect even more because we are starting to treat his retina as well. We'll continue with the other intervention with anti-VEGF, injections, etc. Dr. Katz, I would like to know your opinion and what do you think? What do you know about the presentation and all your experience? Please share with us.
Well, first of all, that was a great presentation. Covering neovascular glaucoma and presenting this case. So I appreciate that. And I think you underscored the importance of really diagnosing it early. I think the prognosis is best if you diagnose it early before you get synechial angle closure and then really elevated pressure. So in the beginning, the signs are very subtle anteriorly. So we really depend a great deal on posterior segment examination and having a great deal of attention to any changes indicating ischemia. And, at one time early in my career, it felt like I was doing 50 or 60 cases a week of tube shunts and trabs for neovascular glaucoma. And I think with the explosion of obesity in the United States, there's such a high percentage of people that are overweight, and diabetes has just gone way up in our country, and many of them are really difficult management cases in general with their health. And so the introduction of anti-VEGF has been a great, wonderful addition to pan-retinal photocoagulation for cutting down the release of vascular endothelial growth factor. And with the introduction of anti-VEGF, I think that's just made a world of difference and cut down the super aggressive, horrendous cases that we see to a more manageable number that were sent in. We learned with experience that trabeculectomy in our hands just had a really very poor prognosis of working if you have active neovascularization. If you happen to have somebody that has regressed their neovascularization and you want to try a trabeculectomy, maybe that would work, but certainly not with active neovascularization. We just had poor results. Tube shunts were great because the other choice, if we couldn't do a trabeculectomy before tube shunts were available, we used to do ciliary ablation, either with cyclocryotherapy and later with laser cyclophotocoagulation. And again, that's a very unsatisfying procedure in these cases. They're ischemic to begin with, and then you do cyclophotocoagulation, especially with cyclocryotherapy. There's a high rate of no light perception and ptysis. So tube shunts for preserving vision, like in this case, you had a fantastic outcome. And as you hinted, clearly there is never a safe ground. These are patients that often need more than one procedure during their lifetime. And then it's always a dilemma where if you've done a tube shunt and you've gotten a good result or it's just not quite adequate, it's better, but not quite good enough, what do you do next? And then we've toyed with either putting in a second shunt or a third shunt, as opposed to going to a ciliary ablation if medical therapy supplementing was not adequate. So these cases can be very challenging. And fortunately, with the options we've just gone through, that you've gone through with your case, I think we've done a much better job at preserving vision in these patients. A lot of these patients, I remember when I was a resident, a lot of these patients ended up not having any useful vision at all. And pretty high enucleation rate at one time for these type of cases. And now enucleation for kind of end-stage neovascular glaucoma is just not common. So I think we've done a much better job. I don't know, Rick, if you have anything you want to share too.
Yeah, a few points. Those were all great points. I think the anti-VEGF compounds have been a godsend, especially in reversing all the vessels that normally bled and gave us all our gray hair in the operating room. And to Jay's point, if you can save the angle through early intervention, that's the turning point and the prognosis for an eye. If the angle closes, that opens another chapter that's not so great. I think in going after a shunt procedure to a cyclodestructive procedure, one of the things I look at is, does the first shunt have a valve in it? And if it's a non-valve large shunt, you're probably more likely to get hypotony. And I might actually put a second shunt in that case, maybe a second non-valve shunt. Timing on PRP is something that gets out of order sometimes. A lot of times retina will want to put in their 1,000 or so spots into the choroid, and then you're going to do a choroidal torture test with surgery. So I think the timing on PRP is especially with the anti-VEGF compounds, should be after surgery. And I've finally, I was able to convince the retina doctors that this was not a good idea to have an eye with 60 that they were doing PRP on, and it would be better to do something definitive, get the pressure down, save the eye, and kind of go down from there. On the surgery, one of the pictures showed a tube that was tacked to the scleral surface with non-absorbable sutures. Probably that's not the best choice. I know that sometimes in Armenia, the supplies are really limited and you're lucky to have suture material, but if you have a choice between a non-absorbable and an absorbable suture, always pick the absorbable suture. Otherwise, the sutures, especially with the knots exposed, will give you a sandpaper effect and tear through your conjunctiva. Jay mentioned trabs with mitomycin. I really weren't doing them. And then a certain glaucoma specialist to the south, Bob, actually, Weinreb teased me about this. And I actually did one just to spite him that actually turned out okay. So, oh, well, but in general, I would use a shunt in this situation. And I did that one just to spite Bob, but it turned out to be a good thing for the patient. In terms of carotid artery disease was on the differential diagnosis. These eyes are kind of peculiar when they come in. They look pretty much full-blown neovascular glaucoma, but the pressures are always down because of starvation to the ciliary body. So if you see something where the eye should have a pressure of 60 and it has pressure like 24 or 25, have a listen to the carotid arteries as well. I think that was a very nice presentation, actually. Good job.
Thank you very much. Dr. Hill, can I ask you something? You said that when you put absorbable sutures on tube part or on sclera? When we cover both? When you are tightening, when we are putting the sutures on a tube part on sclera, you put absorbable as well?
Yes, because otherwise, if you look back at your picture, you've got very large foreign bodies just under conjunctiva, especially if the knot is up. Every time the eyelid slides over that, it tears at the conjunctiva.
Mm-hmm. We mostly we put a panel or nylon on when we are connecting like a tube with sclera. Then when we cover with the cadaveric sclera, then we put vicryl observable. That's why we were not using absorbable for the first step when we're just connecting tube with sclera. Yeah. We'll always use it. Okay, for future we will keep in mind and we'll do. Actually, mostly you taught us to put nylon in the past. That's why I will continue doing that.
I mistake.
90 years ago.
I'm old school too. I'd still do nylon, but for the reason Dr. Bill mentioned,
Thank you, Dr. Katz.
I rotate the knot, so it's kind of very underneath. It's not on the anterior surface. But having said that, there is a movement afoot. Everything is really geared towards speed now for a lot of surgeons in all specialties in ophthalmology. And a lot of people have put in shunts. They don't suture the reservoir at all.
Okay.
Why?
Because they just push it farther back, especially the valve shunts like an Ahmed. They just, my colleagues at Wills, the younger guys, 99% of the time it was fine. You just let it go posteriorly as far as it can go. And then you put the tube in, and it usually stays posteriorly. It doesn't come anteriorly with that.
Do they suture around the tube, or
they do suture the tube? Not always, but frequently they suture the tube, but not the reservoir. And there's also a movement to not have any donor material. Some people. Well, I always use donor material to cover the tube, but if you have a very long tunnel, some of the surgeons in Mexico City have been doing this for years. You just create an 8 millimeter tunnel with a special bend in the needle to create a tract, and you just thread the tube through this 8 millimeter tract into the anterior chamber. And they've done it so often, it's second nature to them. There's no donor material at all, and it's just intrascleral the whole way. So, they push the reservoir back, they create the tunnel, put the tube in, and pull the conch down, suture, and it's literally an 8-minute procedure.
Yeah.
Dr. Katz, but I would like just to continuing, as you said, even the day before yesterday, we had a surgery and the residents were with me. It was the first time in my life, in my practical life, when I put the Ahmed valve posterior, it went very low back. So if I wouldn't bring it back and suture it on sclera, then it would, I couldn't catch even to bring back. We did our best. And that's why I am on that side when it should be always sutured on sclera.
I agree with you. That's the way I've done it for years, and feel more comfortable suturing it. But I just wanted to give you an opposing view that's certainly catching on because of the speed and the lack of problems, according to them. So,
well, after about 6 weeks, your shunt is encapsulated anyhow, and it's mobile. But in that first 6 weeks, you better hope that the tube stays where you put it. They may take the tube down to the sclera, and if you do that, your shunt's not going to move. It's tethered, but it's basically tethered then in a faster way.
Right. I mean, that's what they think. But like you said, if you shove the reservoir back, it usually stays there even early postoperatively. But if it comes anteriorly, that's a nightmare, and you can't leave that. You have to go back in surgically and take it out, or try to shove it back in and suture it down. So, but again, according to the advocates of that technique, that doesn't happen often. Although it does happen, but it's like 1% of the time. Something really.
Yeah, that's you're right. Exactly 1%. Among 100 cases, only one. But when one happens, then you'll just.
That's the one you remember. That's correct.
You lose all your.
I just wanted to bring up one point. It's rare, but it has consequences. And if you see somebody that's not a diabetic and has unilateral neovascularization, and nothing in the other eye, nothing systemic, you got to be careful. Whether it's kids or adults, think about tumors. Unfortunately, there have been cases where for even childhood tumors like dictiomas, people put in shunts, and they've seeded the orbit with tumor. Same thing with ciliary body melanomas. I mean, those are not common, but if you misdiagnose that could have tremendous consequences. So that's something to keep in mind. If the clinical picture just doesn't give you the answer easily, look very carefully. Don't assume it's ocular ischemia. And certainly if it's a patient that doesn't have diabetes or vein occlusion, I mean, look very carefully at the structures in the eye. If anything seems suspicious, think about a tumor.
Yes, thank you very much. Dr. Hill, and as I noted also in the past when we were doing COMET well, very often strabismus was happening. For recent practice, I don't see the cases with strabismus after Ahmed shunt. What do you think? What's the reason? Did they innovated something, or just we became more experienced?
That one. There's an old joke, a Groucho Marx joke. He's an old comedian here, and the patient comes into the office and says, "Doctor, I broke my leg in 3 places." And then Groucho Marx is dressed up as a doctor, and Groucho Marx says, "Well, don't go to those places." And as we get more experienced, we know what those places are. We don't go there.
Thank you very much. Also, I would like to ask Dr. Papoyan as well about his opinion, what he thinks about it. And we have an Doctor.
Thank you. It's very hard to talk after this kind of specialists. Just one comment. A couple of years ago, when we work on guidelines of neovascular glaucoma for our Armenian specialists with Dr. Voskanyan, I remember that we just remarked one sentence. It was that the first choice of surgical treatment of neovascular glaucoma is the valve. It's not trabeculectomy, it's shunt surgeries. So it's very important just for us, our local specialists, that the first choice of the surgery is shunt surgeries. Just one question, Dr. Katz. Let me just know how you decide to do the shunt or the cyclodestruction, and also can you do it when the patient have in vision eye, or you always do it when there is no vision or very advanced glaucoma? Thank you.
Yeah, I mean, it's always difficult, certainly for the first operation, if it has useful vision,
I'm sorry, in Wales, I'm so sorry. In Wales, I see more cyclodistraction. Yes, you did it. So
I mean, if somebody had useful vision, I personally would always recommend doing a shunt in an eye with useful vision as the first procedure. And there are some patients who just, for whatever reason, are not a candidate. They refuse to have it, or their medical condition is just so poor that they're not going to go into the operating room. And we used to do cilioablation right in the office with a block. But when you're getting to a second procedure, then it gets even a little bit more difficult, because the patients are reluctant sometimes to undergo yet another tube shunt, which didn't work in the first place. But you try to explain to them that sometimes you need more than one to control their pressure. But again, I think if they have useful vision, I always err on the side of helping aqueous get out of the eye. I think they're at high risk for having problems, ending up with ptysis or hypotony, and making the vision even worse. But, if the vision's really poor and they have a good other eye, and their vision's so poor, like hand motions are worse, and they really don't want to go through repeated operations, then I think a cilioablation is worth trying, especially if they're having discomfort in the eye and pain from the pressure being elevated. I think it's worth trying there. But having said that, there are some people that have cilioablation with neovascular glaucoma as the first or the second procedure, and have had good results. If you do a limited amount and you don't overtreat, and you tend to undertreat if you can, if you're not sure how much to, it's always a guessing game. So if you're not sure, treat 180 degrees or 270 degrees. And if it doesn't respond, then you go back and do more. So staging the cilioablation makes sense to me, rather than being really aggressive the first time around. So you kind of, it really does, it's a case by case decision often. And, I don't think there's a stick diagram that applies to every patient. You have to kind of talk to the patient and judge what they're capable of, and you give your best recommendation. But I always err on the side of good vision of sticking with outflow, improving that rather than decreasing inflow.
Thank you very much, Dr. Katz. Dr. Hill, do you have anything to add or?
No, I agree. I always respect the physiology of the eye and the cyclodestructive procedures. I'm really leery of in eyes with neovascular glaucoma. They're all already very, very sick. I think if you have a choice, a valve implant and cyclodestructive procedure works a little bit better in terms of lessening the chances for hypotony. But having said that, I did put in quite a large number of non-valved implants.
Thank you very much, Dr. Thank you. We have a question from one of our, Dr. Katz, sorry.
Oh, no, I just had a quick point that for these type of cases, we often did combined surgery with the retinologist. If they're doing a vitrectomy for a vitreous hemorrhage, for example, after they've done their vitrectomy, we'd stick the tube through the pars plana, and we were pretty happy with those combined procedures. So you don't have to worry as much about the cornea having the tube in the vitreal cavity as opposed to the anterior chamber.
Yeah, good point.
Thank you very much. We have a question from one of our doctors, Dr. Marian Pogosyan is asking that, as the first she says, that thank you for a very nice presentation. Thank you, our residents, the doctors. And the question is, if we have neovascular glaucoma with high pressure, and before, and we need to do anti-VEGF, we need to do intravitreal injection. Can this be done before surgery? Because if the pressure is high, can this be dangerous? Or we do shunt surgery and then do anti-VEGF? Dr. Hill, what's your opinion about that? To do the anti-VEGF injection before shunt surgery or after that or during the surgery?
Before, during, and after. You have to remember that fluids are relatively incompressible, so that if the eye has a pressure of 60, don't put something more into it until you take something out. And a paracentesis can be easily done. And then a paracentesis for the same volume of what you're injecting can easily be done. But as I mentioned before, the anti-VEGF compounds have really been a blessing for surgery in the neovascular patient.
Dr. Katz, what's your opinion about this kind of case, this patient?
I think Dr. Hill's points are good. I think what you have to keep in mind, though, is that you're right. You don't want to inject fluid in an eye that has a pressure of 60 and raise it to 90 and have an artery occlusion. But on the other hand, if you do a paracentesis, you also have to take a risk that you can have some bleeding from these fragile neovascular vessels, whether it's into the anterior chamber and getting a hyphema, or even posteriorly, more of a vitreal hemorrhage can happen. So there is some risk, but these are eyes that are pretty sick, and you're trying to help as quickly as you can. Turns out many times that we if somebody really has an extraordinarily high pressure, we're going to treat them very aggressively, both medically and surgically. So we're getting into the operating room pretty quickly, and many times the retinal surgeons would just defer until they get into the operating room to give the rant. They're already going in there quickly. They're just going to wait in a controlled setting to give the anti-VEGF the first time. That's a decision I leave up to them.
Thank you very much. I completely agree with you. And in our practice, what we do, all our cases with neovascular glaucoma, the anti-VEGF injection was done before surgery. Maybe it was one day before, but mostly, again, as you said, and as Dr. Hill and Dr. Katz mentioned, we can do paracentesis if the pressure very high. But in our practice, mostly we put the patients under aggressively Diamox or the medication similar to like carbon hydrase inhibitors, locally, general, aggressively, to bring something down to be able to do anti-VEGF injection. And thanks to our experience, we never had any such severe problems with the injection itself. If the eye was moved, that brought in a quiet condition. So, but the better results we have, if we do anti-VEGF injection even one day before, we see like the neovascularization goes a little bit, becomes less aggressive. So the Ahmed valve implantation doesn't cause as much hyphema or lots of bleeding, or the vessels are not, they are going a little bit behind. So again, this is very, Dr. Papoyan, what's your opinion about what anti-VEGF injection and the surgery went to do?
I agree with you all. So we are just doing before surgery, and Dr. Rick said after also. So it's very important to do the before and after surgeries.
Like before you do to have a success with surgery, after we do to keep the vision, whatever we got.
And also to delay the PRP till the wounds heal.
Right, sure, to treat completely. Any questions? I think the time is already. No, we're good. Yeah, we are very good. And I would like first to say thank you, Dr. Gill, Dr. Katz, for your time, for your very, very, I know, very dear experience and thoughts. You, as always, you helped this country, you helped our hospital, you helped our patients, and all of us personally. Thank you very much for all you have done, you do, and you continue doing as always, never stop. And I would like also to say thank you to our introductors, the doctors, third-year resident and second-year residents who did a lot. They were working with patients to prepare this presentation. I think they were good, especially if the language was not there, it was not Armenian, but I think they were good. I'm very excited with them. Thanks to Vahan Papoyan for his. Thank you very much. And of course, again, I would like to say thank you, Nunay Yazarian. He does all these things very easy. Dr. Miriam, Miriam, chief of our hospital, to all eye care project, especially Raja Ohanisian, to make this possible.
Yeah. Well, with all the thank yous done, the only thank you is now for me to say to Lilith for leading this discussion, having a wonderful time. Of course, thank you, ladies. That was very encouraging. Thank you, Dr. Gatz, and thank you, Dr. Gill. So I'm more than sure that we'll continue doing such very interesting discussions, and we'll invite you again. Thank you very much, everyone. Thank you, Vahan, for your diplomacy.
Thank you very much, and have a good day. The day just started for you.
Thanks for having us.
Thank you.
It was a pleasure being with you.
Bye.
Good to see Dr. Hill as well.
Thank you very much.
Bye-bye. And congratulations to the residents for a great job.
Nice.